Today, we're jumping into a real medical detective story. It's a situation where a super common symptom, a fever, suddenly becomes a signal for a life or death emergency. We're talking about febrile neutropenia. So let's start with a question that gets right to the point. I mean, for most of us, a fever just means you're sick, you need some rest. But what if I told you that in some cases, it's a blaring alarm bell for a race against time? When does a simple fever become something so much more? Well, the answer is right here in this condition, febrile neutropenia. You gotta break it down into two parts. Febrile is the easy one. That just means you have a fever, specifically one that's at or above 38.3 degrees Celsius. The second part, neutropenia, means you have a dangerously low number of neutrophils, which are the frontline soldiers of your immune system. And when you put those two together, that's a huge, huge red flag. Okay, so how does a person even get to this really dangerous point? It doesn't just happen out of nowhere. It's all about how the perfect storm gets created, making someone incredibly vulnerable to infection. I want you to think of your immune system like a fortress. Now, chemotherapy is amazing at attacking cancer, but it's not picky. It also attacks your bone marrow, which is the factory that makes all your blood cells. This is called myelosuppression. And what happens when the factory shuts down? You get neutropenia. Suddenly, your fortress has no guards. But it gets worse. Chemo can also cause something called mucositis, which damages the lining of your mouth and your gut. So now the walls of your fortress are breached. No guards, broken walls. The risk of a massive, overwhelming infection just goes through the roof. And to really put this into perspective, let's look at the numbers. A healthy person has way, way more neutrophils than this. But in severe neutropenia, that count just craters to below 0.5 times 10 to the 9th cells per liter. That is a tiny, tiny fraction of a normal immune army. The patient is left almost completely defenseless. So the alarm bells of a fever are ringing, and the investigation kicks off immediately. Clinicians have to become detectives, and their number one job is to find the source of the infection. The only problem? They're usually hunting for a culprit they can't even see. And this right here, this is the most maddening challenge of febrile neutropenia. In a staggering 70 to 80% of cases, even after all the tests, the specific bug that's causing the fever is never actually found. It's like you're trying to solve a crime, but you have no suspect, no weapon, nothing. This means you have to be incredibly smart about the tests you run. The do's are absolutely critical. A super careful physical exam, and most importantly, drawing 2 or 3 sets of blood cultures before you even think about starting antibiotics. But the don'ts are just as important. Doing a routine chest x-ray if the person isn't coughing or short of breath, not very helpful. And a urine culture, pretty much useless. Think about it. A UTI is usually flagged by white blood cells in the urine. But if the patient has no neutrophils to begin with, you're not going to see any. So because we can't find the enemy most of the time, we absolutely cannot wait for proof. We have to launch an immediate, massive counterattack. We have to fight an enemy we can't see.
You know, this whole thing really requires bringing different parts of medicine together, which, as a quick aside, isn't always so easy. Why did the microbiology professor break up with the organic chemistry professor? Well, they had no common bond. Okay, back to the serious stuff. Let's talk about the battle plan.
The main strategy is something called broad-spectrum empirical antibiotic therapy. That sounds complicated, but empirical just means you're making your best educated guess. You're using powerful antibiotics that kill off all the most likely and most dangerous bacterial culprits, and you're doing it right away. It's kind of like sending in the special forces, because you don't know if you're fighting one bad guy or an entire army. For adults who are at high risk, treatment usually starts with what we call monotherapy, just one single really powerful drug. The big guns are usually cefepime or piperacillin tazobactam. These are heavy-duty antibiotics designed to take out really dangerous bacteria, especially a nasty one called Pseudomonas. But is it always about just piling on more drugs? Nope. You only add more firepower, like an antibiotic for a different class of bacteria, in very specific situations. If the patient is in shock, or if you're pretty sure their central line is the source of the infection, or if you know they've had resistant bugs in the past, then you escalate. Otherwise, you stick with that single powerful agent.
All right, so that's the playbook for adults, but what happens when the patient is a child or even a newborn? The rules of the game are completely different.
For newborns, the list of usual suspects is totally different. Here, we're more worried about things like Staph aureus or Group B strep. So the initial treatment reflects that. It's often a combination, like flucloxacillin and gentamicin. And if the baby is getting worse, or if there's any suspicion of meningitis, you upgrade again to an even more powerful combo, like vancomycin and ceftazidime. So, after launching this all-out assault with antibiotics, the next critical phase begins. And in some ways, it's the hardest part, knowing when to stop. How do you close the case without over-treating the patient and causing other problems? It really comes down to a crucial decision point at the 48-hour mark. After 2 days on these strong antibiotics, the clinicians take a step back and ask 3 simple questions. 1. Is the fever gone? 2. Are the blood cultures still negative? And 3. Is the patient looking stable and getting better? If the answer to all 3 of those is a solid yes, it's usually safe to stop the antibiotics, even if their neutrophil count is still super low. And there is one last rule that is absolutely non-negotiable. A central venous catheter, or CVC, can basically act like a superhighway for bacteria to get right into the bloodstream. If there is any reason to believe that line is the source of the infection, treating with antibiotics isn't enough. The line has to come out, period. And all of this, it brings us to one final, really critical thought. Every single time we use these incredibly powerful, broad-spectrum antibiotics, we are walking a very thin tightrope. It leaves us with this fundamental, nagging question. How do we save this one patient's life today without helping to create the superbug that could threaten countless lives tomorrow? It's one of the biggest dilemmas in modern medicine, and a challenge that really all of us have a stake in solving. Thanks for digging into this with me.